Hi, I'm here with my friend Dr. Lee Kudrow in his home in Beverly Hills.
Hi to my friends and colleagues. Pleasure to be here.
Lee, you're my mentor. We met in 1979 when Fred Sheftel and I came out to train with you. You taught us pretty much everything we needed to be great headache specialists. And some of the things you taught me were so critical that I wanted our audience to learn some more about them. The most important thing that I recall that you taught me that I've used all my life was that the overuse of acute care medications for headache, especially analgesics, produced increased headache and lack of response to medications in people who already had chronic headaches.
About 2 years before I met you, I was already interested in the observation that people with daily dull to moderate headaches used an excess amount of analgesics frequently. So it became a question of the chicken and the egg. Was it that the medication itself was causing the chronicity of headache, or was it the other way around? Well, I had the opportunity to study it because I had already seen about 2,000 patients a year for about 8 years, 7 to 8 years before I met you. I had the opportunity to publish it in 1979, and it was published in Postgraduate Medicine. It was a pain conference, it was a symposium, and I was the only person that spoke on headache.
I can just see it now. You're telling pain people that using pain medication are going to make the patients worse.
Especially since the program was financed by Riker Laboratories. That was essentially interested in one of their medications, an analgesic medication, which incidentally worked in the treatment of migraine.
Sure.
Which was occasional and mild to moderate migraine. But this was a different case. It was daily, dull headaches. I designed the study with 200 patients. 100 patients were on amitriptyline, which was known to treat chronic daily headaches. The other half were non-amitriptyline patients. There were two subgroups in each group. One subgroup was no analgesics, and the other was continue analgesics. And that was true for both subgroups.
How did you come up with the idea to do such a sophisticated study at that point on this?
Right, because most people who were treated properly were in fact treated with amitriptyline, but the results were partial. So in this case, we had a sizable number of patients that were put on analgesics and that were excluded. A lot of patients who were not permitted to have analgesics dropped out.
And weren't on amitriptyline.
And weren't on amitriptyline, especially. We lost about 40% of the patients. But within that month, we made up with bringing in new patients so that they could fill that 200 patient quota. And what we found was, I think, something remarkable. That it's true that 25 to 50 milligrams, as Lance had shown, of amitriptyline benefited a good percentage of the patients.
I'd just like to point out that it was Jim Lance from Australia, because I think he is coming to our meeting and is probably in the audience. So please say hello to Jim right now.
Hello, Jim.
We wish you were here.
The results of the study was such. Patients who had amitriptyline and no analgesics did best. About 80% of them lost their headaches. On the other hand, people who were neither on amitriptyline but were allowed to take their medication, there was no positive result at all. No positive.
None at all.
None.
That's
That's
amazing.
on top of the 40% that dropped out because they could not stay away from analgesics.
So you really nailed it.
I was very happy with that, and I published it again in Critchley's book from Advances of Neurology.
Who was head of the Institute of Neurology in London.
That's right.
And a world-famous headache specialist.
That's right. And I published it then as paradoxical effects of the frequency of analgesic use. If one used analgesics frequency, they would actually get an increase in their headache frequency. analgesic rebound.
The term isn't used except by us older people. The term now is medication overuse headache, and it pretty much means the same thing that you meant with analgesic rebound. Would you agree that not 100% of people will improve by just stopping their analgesics?
That's correct. There's 100% of nothing, nowhere. Right.
If it's published as 100%,
Right.
we don't believe it.
Right. That's right.
It's become a more important concept in headache care every year. And today, somebody that doesn't know it or understand it is probably not a very good headache clinician. So we all thank you.
But I thought it was kind of obvious, I must say. And I think it's because I had so many patients that I was able to feel it and then, study it.
The second thing you taught me that was rather critical was that every time you take a history and you ask a question, you're going to get an answer, and you have to digest that answer and follow it with another question. And this keeps going on and on. And if you ask pretty good questions and you get reasonable answers, at the end of this period of time, you're going to nail the diagnosis. You also pointed out that you can't do this in 5 minutes, and most doctors then had 10 minutes. Today it's only 5 minutes. Speak a little bit about asking a patient their headache history.
A difference between the old days and nowadays. Now people see their patients in the examining room.
Or the hallway.
Or the hallway. It's uncomfortable, you're in a rush, but in a nice consultation room, a patient is comfortable and you can afford to be patient because it's a good environment.
The third thing that you really impressed us with, which of course we hadn't done up until that point, was to make the patient keep a headache calendar. I still remember a story you told me where a patient had come to see you for the second time. You had obviously given her the calendars and said, please come back with your calendars. And I'm sure when she left, the secretary said, and don't forget to come back with your calendars. So she came in and the secretary said, can I have your calendars to give to the doctor? And she said, oh, I left the calendars on the counter. I'm sorry the doctor won't see you. I just drove here for 2 hours all across Los Angeles. What do you mean he won't see me? Those are the rules. We told you very carefully.
It's a true story, and the importance of the calendar can't be overstated.
Some of the people in the audience have never heard of you because you retired, 15 years ago?
20 years.
20 years ago. They didn't know that you were the first person to write a book on cluster headache. How did you get so interested in cluster headache?
All right, so now we're talking about compassion. Because I had my first cluster headache when I was 22 years old. I burst out of the room while the professor was talking. I ran into the quad, which was all beautiful concrete, lay down on my knees and slammed my head against the floor to knock myself out. There was a crowd around me. I leaned against a tree nearby and said, I don't know how anybody can take this. If I have it, other people must have it.
You had no idea what it was.
I had no idea what it was. There were very few neurologists that did know cluster headache. And I thought that was shameful. Knowing what I went through with 1 or 2 attacks a day, 3, 4 months at a time, I decided then that a patient deserves compassion. You have to feel for the patient. And there is no better example of this when we talk about daily dull headaches, you have to feel for them as well, than exhibited by Fred Sheftel.
Fred was an amazing doctor, a great psychiatrist, but a really great headache specialist.
Fred exemplifies this issue of compassion for the patient as well as you. And he said it in the lyrics of a song that he wrote.
Should we play the music?
Let's play the music.
She gets up each morning with that pain in her head, but there's pills on her table right next to her bed. Will it be aspirin or Vicodin? She don't know where she's going, but she knows where she's been. She's a rebound lady on a highway to hell. She keeps medicating, she ain't doing well. Went back to her doctor and asked him for more. Sir, little lady, that's what doctors are for. She's taking more pills, she ain't better at all. By noontime she's taking Fiorinol. Then it's the codeine and good old Stay-Doll. She'll just tumble around and bump into a wall. She's a rebound lady on a highway to hell. She keeps medicating, she ain't doing well. Went back to her doctor and asked for some more. And when she got worse, he showed her the door. It's off to the hospital, time for IVs. Detox and Botox, IVDHE, Confazine, Defecon, steroids as well. Discharged on topiramate, now doing well. She's a rebound lady on a highway to hell. She's still medicating, she ain't doing well. She's traveling this country and Europe as well. She's that rebound lady on a highway to hell. She's traveling this country and Europe as well. She's that rebound lady on a highway to hell. When's she gonna stop?